to share progress on that over the forthcoming weeks. So the one thing that I did want to touch upon, and is an area that I know we're going to try and find some time to discuss with you in more detail in a development session in the forthcoming weeks, is around the radiotherapy performance in VCC. I think we're continuing to experience some challenge in terms of meeting some of the targets. But before I get into the detail of that, I'm just going to stop for a second and remind us the fact that we're actually now reporting, as I mentioned earlier, against two different sets of targets. The one are the standard targets that we've been reporting against for some considerable time. And secondly, the new aspirational targets from COSC that have come from the Cancer Network, and that we started reporting against with a view to reaching those more stringent waiting times. Historically, we've a couple of months back, we had a presentation on some of the changes in that and what that actually means. So we're still working to aiming to achieve those waiting times. Just wanted to advise you that because we're reaching a sort of low compliance with those targets, we are in the same place as the other centres across Wales in terms of our aspirations to meet those targets. And we'll be continuing. We've been joined by a member of staff that's working for both us and the Cancer Network, who are going to support us to really focus on some of the pinch points and some of the handover points and the ways in which we can actually just improve the compliance with those targets by improving the flow of patients through our pathways and making those pathways as sleek and effective and efficient as they can be. So that'll be a piece of work that will take us through into the next financial year, and we'll be able to give you an update on that when that piece of work gets underway in some more detail. So in the meanwhile, Can
I just ask you,
of course,
before you move on from there? So the Cancer Network, they have provided us with the cost targets, and I've got two questions in relation to that. If these targets are more stringent, you know, I've got no quarrel with that, but did any resource or support come with that? Because obviously there's extra work for colleagues to do, or certainly to meet those different expectations. Did anything come with that? And is there a real dip in performance, or is, when we're looking at the various breaches, is if we were using the previous method of reporting, would we have seen a dip in performance?
Yes, absolutely.
Okay.
So in terms of the first question, where it sits within our commissioning model, there's been no specific funding received to make these service improvements. I think there's an expectation that they would be aligned with our general strive for continuous improvement in our services. However, the tremendous work that was done by the finance team in more recent years in terms of modifying our commissioning framework means that we now have an opportunity to look at the changes in our radiotherapy provision, but also in the provision of other elements of our service across Velindre, and returning to have conversations with the commissioners. And I think the important thing is that the piece of work that we're doing now to map those pathways, to use standardised national pathways that are being developed in collaboration with the network, will enable us to really identify exactly where some of our challenges are and how they can be met. And then if there is a requirement for additional funding, then that can just be taken through the standard process, and we'll be ably supported in that by Matt and his team.
So that preempts one other question I was going to ask. So thank you for that. And so is there a real dip in performance, or is it about, because it's a different reporting mechanism?
A bit of both. So what we've presented today are the two different measures. So we are seeing a real dip in performance, and I'm going to go into some detail about exactly what the problems are that we're experiencing and what we're doing to address that, and also some of the constraints that we anticipate will continue for some time, but we're working towards. So you will see that overall we're seeing some red figures on our compliance against the standards and the waiting time targets, and they have reduced. As with everything else that we do in the Cancer Centre, everything is multifaceted and complex. So I'm going to give you a brief overview for today, but we can get into an awful lot more of the detail underneath that in terms of providing you with assurance when we have an opportunity to spend a little more time. I wouldn't like to get into too much detail today and let our agenda run away with us. So hopefully a bit, some points to be mindful of, and then further discussion when we can. So what we're seeing at the moment is that we've returned to 95% of pre-pandemic levels in terms of patients, and that they are coming through to us in a variety of patterns. We're really pleased that we've got the information provision, improved information provision from the work we did with the delivery support unit and the health boards back earlier in the year, which is now giving us a greater clarity of the timelines that it's taking, of the patients that are coming through the system. But also we're noting that some of those patient pathways in the health boards are becoming more of a challenge. So what we are seeing is that because of some of the reduction in surgery provision in the health boards, we're seeing some patients for whom their first treatment is going to be radiotherapy, which is starting to slightly sway the balance of patients that come to us pre or having already had some surgery, or are coming to us for radiotherapy for their first treatment. And we're working with health board colleagues to try and understand that better and what the pattern of that might look like. We're continuing to run with a 25% reduction in our capacity because of the infection prevention control measures that we had to put in place to respond to the pandemic and keep our patients and our staff safe. We are also seeing increases in staff absence that are reflecting the overall occurrence of COVID in the general population. But what we're also starting to see in the last month or so has been an increase in the numbers of people off with the normal winter bugs that we would anticipate at this time of year. So we've got that additive effect. The impact of which is being that last week we're actually running with a whole LINAC provision of staff under what our normal headcount would be. And there's a number of things we're doing about that I'll come to in a second. So we are also seeing, we had a couple of weeks ago where we had a spate of breakdowns of our machines, some of which the repairs take longer. We know we've got an aging fragile fleet, and the IRS procurement obviously proceeding to help us out with that, but that's not going to be an immediate fix. And we also know that we had some increased capacity because we introduced hyperfractionation, but we also know that that has an increased burden in our medical physics. So quite often when we're talking about our performance, we're looking at the provision of treatment on our LINACs, but actually, as we're all aware, we know that it's very much more complex picture with the requirements that patients need right across that care pathway, from the CT scanning for planning to the planning undertaken by medical physics colleagues, and to the medical input into that, as well as just that endpoint treatment provision. So all of those factors and some of the patterns that we're seeing in different patients with different tumours at different sites coming through, all this variation is increasing the pressure in our system. So what are we actually doing about it? As Stephen mentioned earlier on, as we've started to come under even more pressure, that we have stood up the management intervention that we would see, and the oversight that we're having of the plans being undertaken by the radiotherapy team, and also our clinical colleagues, our medical colleagues as well. So we've got that escalation of that. We have expedited recruitment. So Workforce and OD have supported us in terms of expediting some of the recruitment and the registration of some of the new qualified professionals that were coming on board. We have also seen a delay in some of those students actually qualifying because of some of the delays in their work placements, obviously, which caused us another challenge, but we've been supported in that by Workforce and OD. We have reached out to a contractual provision we had with the Rutherford Cancer Centre to make use of their LINAC capacity at their site in Newport, and we're trying to make sure that we can streamline, making sure we get the right patients for treatment there at the right time, and that we make the most of the capacity that they have to offer. So we already had one contract in place, and we've also met with them to see if we can increase any of that provision in any way. We have returned to the frontline staff who were appropriately qualified, but maybe had non-patient facing roles now. And we've increased hours where we can. We're also looking at cross cover between different staff groups as well. And the site-specific team groups of clinicians have developed a clinical prioritization matrix, which is being finalized now to enable us to make sure that we're making the right clinical choices. We're also making sure that we're communicating with patients when we start their treatment process, which will then start with their planning scan, and making sure that we're keeping patients advised of when they can anticipate their treatment to start. So a highly complex picture of our actions, which we will continue to focus on over the forthcoming months and give you some more detail. One of our big constraints continues to be our LINAC fleet and the age of some of the other systems that we're using. So we're continuing to make the best we can of what we have, whilst looking forward to the new equipment coming in the future. So I'm going to pause there and see if anybody's got any other questions on that before I move on to any other aspects of our performance across the organisation.
Thank you. Thanks, Kath. I can see David Cogan. Can you take your mute off? There we are.
Sorry, Chair. Kath, just a question really. You talked about three elements there, if I've understood it correctly. Reduced capacity in terms of where we are, staff absence, and then vacancies. Is one driving more than the other? I suppose I get the feeling a little bit when you did the summary that perhaps resource is quite a challenge at the moment, not in terms of absence, but trained people, the ability to have the numbers you require to improve the service. I just wondered, is that a big contributing factor at the moment, just having enough resource outside of people not being able to work because of being isolated or having COVID themselves?
So there's a yes and no answer to that, I'm afraid. So it is a complex picture. We are experiencing staff absence. We know that we now need more staff to run the system to bring us up to capacity because of the requirements that we have to operate in a COVID world that we're going to continue to experience for some time. But what we also have is that there is a shortage of NHS workforce, and we're not alone in experiencing that. All of the health boards right across the UK are experiencing that. But what we're also having is an increase in the complexity of some of the tasks that we have to undertake. So, for example, in medical physics, we're now being required to undertake more 3D plans, which require staff to have additional enhanced training. And obviously that takes some time to get them fully trained. And we already had a plan for that. However, some of the changes that we've made have increased the requirements for that, which have been, out of kilter with what we were planning and preparing for. So I said it is multifaceted, and the workforce continues to probably at the moment be our biggest challenge.
And Kath, my second question is, with delay of treatment, do patients contribute to that in their choice of whether they are making personal decisions for whatever reason to delay their treatment? So they may be sort of described that from a medical point of view, chemotherapy or radiotherapy, as we're talking about now, should start on a specific date. But are you seeing an increase at all in patients taking that personal decision to delay? And then does that report into your performance if a patient does decide to delay their own treatment?
David, that's a really good question. And I know the answer to some of that, and some of that I'm going to have to come back to you on in terms of the overall impact of patient choice. But in terms of patient availability contributing to some of the figures, then it definitely does. One of the factors that we have reported to us is that some patients, we're unable to contact some patients, or that some patients make that active choice. So I know that it does contribute. I just don't have any understanding to hand of exactly what number that constitutes. But I'll make sure that when we're reporting back in further detail, that's one of the elements that we'll pick up. I can see that Jazz has got to.
Jazz might have something to contribute to that. So Jazz?
And thank you, David, for your question. I don't really have the full answer specifically to the question around patient choice in decision making impacting, but I think that what I can share is that there are just many more options for treatment for patients, and I suppose that's a success of where we are with oncology, which does mean that sometimes we'll decide to do, set the sort of ball rolling for a particular path of treatment. We'll then get a scan result and we may actually divert our plan. And one example might be that we will change from what was going to be a simple sort of palliative plan, which would normally be able to be delivered within that 14-week window, to what we call a 3D plan, which is more complex, mainly because we're trying to spare normal tissue and deliver the treatment with reduced side effects. Now that pathway cannot be delivered within 2 weeks. I mean, we're not set up, and we probably may never be. So there needs to be this group of palliative patients that can be accommodated within a 3-week window as a kind of sensible time frame. Currently, we do not have that. We do not have that box to sort of put patients into at the minute, because we have got emergency, palliative, and radical, which is what our IRMA system currently defines patients as. So this is one of the big pieces of work that we are doing in the process of, which will also help us to identify patients for the COSC targets, if that makes sense. So I think what I'm saying is there is a change, and we are seeing this change in the number of palliative patients that are in fact converting from a simple plan to a 3D plan. And that's partly to do with discussions with patients, discussing around choice, also the fact that actually palliative patients have better outcomes. So we may not have worried about this so much historically, but now we're thinking, what is the impact for this patient in 3 years? What is the impact of this radiotherapy I'm giving for this patient in 5 years? So they're still palliative because we're not classifying them in the radical as a radical patient, but actually they're a palliative patient that's going to live for many more years. So this is some of the, in a sense, it's a good news story, but our system is not able to sort of define it helpfully right now, but we are working on that. And this is some of the work that we're doing in an all-wheel basis with the network to try and understand. So I hope that helps. May not have answered the question specifically, David, but it does give a sort of additional lens to what's actually happening.
Yeah, Jez, it does help, and I think the honesty, and I think like everything else, isn't it, that we can all aspire to achieve a target, but there's a story and there's a broader and wider picture beyond that target. And I suppose that my questions were to sort of not tease, but to bring that out a little bit. If patients are making that decision, well, clearly, that's not at the expense of Velindre not doing their best. And at the same time, whenever we talk about patients, there is not one model of patient. So it is a complex matter. So it does help. Thanks. Thank you.
So what I'm going to request, David, Jazz, I accept absolutely what you were just saying. So as this is a public document, which our patients may well read, whilst there are some difficulties in getting the nuances reflected in the performance tables and graphs, I think a narrative would be very reassuring for our patients. I don't understand quite why, but if you decide today that that a patient needs radiotherapy, the clock starts, and then if for various reasons, when you're talking to that patient, you decide to go down a 3D route, or you decide whatever you're going to do, and that will then take some planning. The clock can't stop whilst you then replan all of that, and so it comes out the other end as a breach. And I don't understand why it's so difficult to capture that. Don't take that as a criticism. It is what it is. But I think it would be helpful to our patients if there was something of a narrative. And in that narrative also, Kath, you did say in your presentation that there is a clinical risk assessment. To some patients, 5 patients were waited over 46 days. It would be helpful to know that they were risk assessed clinically and prioritized appropriately. And if that could be, I think we've had this discussion before, if that could be also in the narrative, it would be reassuring to, if I know that you do it, but it's not in this report, and it would be helpful to patients who are accessing and reading this report to see that written there. So that's my request. David, thank you for those questions. They were really helpful, and I agree with you absolutely.
Chair,
Martin? Oh, sorry, come back. Do you want to come back, David?
Sorry.
Right, Martin.
Yeah, Andrew has got his virtual hand up as well, but I'll dive in first since you called me.
I can't. Where can you see? I can't see Andrew.
In the chat line.
Oh, right.
Okay, Kath,
Okay.
I just want to come back to staff shortages, and you said rightly that just like every other health organisation in the UK, we're suffering. And of course, we know that doctors and nurses don't grow on trees. There's a pipeline, and that obviously takes some time. Where are we in terms of addressing that? Because obviously we are looking at for particular specialisms which aren't run of the mill, shall we say, not to denigrate anybody, but clearly we're looking at specialists. That pipeline might therefore be a little bit longer. And I wondered whether we are part of an NHS Wales proposed solution to this, or whether we are ploughing our own furrow in terms of recruiting and training and getting people into our system.
So I can. There are 2 elements to that, and I can see Nick's put her hand up too now, so she might want to come in on this after me. So what we're doing is 2 things. We are operationally workforce planning in terms of what we've got for the next 6 months, 12 months, couple of years, because not all of the training happens, at an undergraduate pre-registration level. But we're also working with Sarah and the workforce team to look at our medium and longer term plans. So we're doing all of these things in parallel. But what we've also got is we've managed to invest in some resource in terms of a workforce planner to come in and work alongside me and the teams to really start to look at what we've got and how we make better use of it. And that is a key element to the work of the Velindre Futures programme, which is actually about, do what only you can do, to make sure that we're delegating the right tasks to the right people. But obviously that's a sort of longer, slower piece of work, although we'll be keenly focused on it. So we're doing all the immediate things we can, and then got an eye on that longer term as well. I don't know whether Nick, and I can see Sarah's got her hand up now, wanted to maybe come back on that point.
So Nick, did you want to come back on that specific point?
Yes, please.
Okay.
You're quite correct there, because a lot of these highly specialist professional roles, there is a lead-in time of 3 to 5 years in training. So we have been, and I've been personally engaging with HEIW and with nationally around how we get a better pipeline for the future, but that is for the future. We've also now looking at very different models of growing our own and training. So we're looking at bringing in apprentice level, band 5s and training up. So we are doing a bit of a hybrid model, particularly in medphysics and radiation protection services, less so with radiotherapy. We've engaged also with the student streamlining process that took into effect for this workforce for the first time last year. And we're working with workforce colleagues to ensure that we're quite clear of what our pipeline is, how we absorb those into the workforce, and how we have our recruitment model then wrapped around that as well, so we don't end up with several months waiting for students to qualify either. So it's a bit of a hybrid model, but dealing with the here and now, the medium term plus the long term pipeline of these specialist staff.
Thanks, Nick. Sarah, is your hand up for to come in on that point as well? I just lost Sarah's picture. There's you're back, Sarah.
Yeah, sorry, that's typical, isn't it? My connection drops just when I wanted to speak. Just wanted to add really to what Nicola said. We are obviously also part of the national conversation around the workforce supply issue that is happening across the piece in terms of the short-term pressures. We have a workforce summit happening next Monday, where we're having a conversation really as a workforce and OD community, but much more than that, with Welsh Government, bringing in other exec colleagues to understand what are the levers we can pull nationally that can make a difference in the short term as well as in that medium to long term approach that Nick described. So I think we're in the conversation and we're working very actively with HEAW where we can to actually address the issues. We're also recognising really that we need to take a bit of a different approach to recruitment. So we're looking at that in the round in terms of workforce and OD, and looking at alternative pathways to attract people into the organisation. So really trying to use every opportunity that we can.
I know this is the thing is we want a quick fix, and this isn't a quick fix.
Mm.
So that's the problem there. Gareth?
Thank you, Chair. Quite apart from the obvious impact on our patients, which we've been discussing, are there any other consequences of not achieving these targets?
Who's going to take that? Excellent question.
Sorry, I just dropped there, and I didn't hear that question. Sorry, could you repeat it, Gareth? I heard you. I just came in at the end of you.
Yes, I was just saying that quite apart from the obvious impact on our patients in not meeting these targets, are there any other consequences that we need to be aware of?
So we report the data into Welsh Government. And we have a very similar discussion with Welsh Government as we're having with you today. So they are fully aware of what's going on and what's happening, and offering us all the help and support they can, that we can identify, they can help us with to meet it. So other than the individual patient impact, which obviously we are trying our hardest to minimise, there are no other sort of system-wide consequences other than our reputation and our pride in terms of wanting to deliver the best we can for our patients. Which is, you know, which is well, I suppose the other thing is actually that does impact back on staff, because the staff are wanting to be doing what they need to do. So that is another maybe unsurfaced consequence.
Kath, I've tried as best I can to see where the comparison between both performance against both targets is. So at the top of the report, you've got, is it the COSC targets?
Yeah.
And then from page 6, it says if you go to page 6, you'll see the other targets, but I can't see them.
Oh, I can't see them either because iBabs has just logged me out.
All right. So it says page 6 for JCCO measure, but when I go to page 6, so I can't make it. You know what I said to you? Is this a real dip in performance, or is it just you know, a different in measurement against a revised target? I can't see the other targets.
Sorry, so I thought the both sets of targets are at the top on page 1. So for radiotherapy on page 1, we've got the compliance with the COSC target and the COSC measure and the JCCO measure at the top of page 1.
So why can't I work? It says patients beginning radical radiotherapy within 28 days. Page 6, JCCO measure. You've got only one measure we have, which is the actual and the target.
So we're only the narrative is only including our analysis of the JCCO measure, but at the top of the page, the COSC measures are included as well. We're not making a direct comparison between the two. They stand alone as different measures because there are different patient definitions within those. I can see a couple of other hands coming up, so I don't know whether or not I'm missing something and somebody wants to dive in and help me out.
We've only got one measure that we're looking at in terms of performance against target.
In the detailed body of the report, in the summary at the top, both are included.
I can't see it. Where are they then?
Page 1.
I'm on page 1 and I can just see, because I'll take this offline, but I can only see one target and one performance figure.
Apologies, Chair. In the appendices of the VCC performance dashboard.
That's what I was looking at.
Oh, page. Oh, that's that page one. Okay, so I'll
sorry,
have a good look at
Chair.
that. Okay, all
Page
right. So neither of us is going bonkers, so we're all right. Okay, I've got Steve and Jazz. I've got a question about brachytherapy I'd like to ask as well at some point. So Steve.
I think Jazz had a hand
Oh,
up
Jazz was first.
actually.
Yes, you're quite right. I just spotted that. Jazz, you're first.
Thank you, Chair. I just coming back to the question that Gareth posed about the impact of this. I mean, I think that it is an important question. I think there is an impact, Gareth, on particularly, you know, as a clinician, then we are aware of the difficulties that we face, and it's, you know, so it's about preparing ourselves for being as efficient as we can, for ensuring that there is no slack in the system, covering each other on annual leave, the kind of pressure on staff to, I suppose, maintain the service, knowing that we're in a difficult place for a number of reasons, then that cannot be underestimated, and absolutely wanting to ensure that patients get the best outcomes. I think there are a couple of other things just to mention as well, is our ability to then participate in research studies where, you know, one needs more time, capacity again, increased complexity. I think that will, you know, potentially be impacted. So we are sort of starting to think about how we can mitigate some of that. And of course, there is that overall reputational risk. You know, we like to have, you know, very good performance figures. We've been used to them. And to some extent, it is going to be a bit of a challenge to just even, it's not very palatable for us to see some of these figures coming through. So I suppose there is the need for us to understand why and work collaboratively to keep on top of this. Absolutely. Thank you.
Thank you, Jazz. Steve, and then Phil, and then Stephen Harris. So Steve Ham first.
Jazz has picked up some of the issues I was going to raise, but the one I would want to focus on again is about our staff. And I think they do appreciate the pressure in the system. They live it every day. And I think when I've met up with people, it's a real issue in terms of how we support people through this. I've met with some staff recently and they're feeling quite fragile around supporting this position as well. And then that's not unique in the system, given where everybody is in terms of, but I think our support for what they're doing in the really difficult circumstances is really important. Whilst we work through the issues that Kath has flagged up, we're working through as well. They are really on the front line facing this every day, aren't they?
Yeah,
absolutely.
No, absolutely. Phil?
I might fully follows on from the last few points. So it's part of working with supporting in terms of the performance reporting is not just understanding performance against the target, which is important, but also what's the system set up to deliver. So it actually could be ever achieved target. So when you take into account workforce, machine downtime, what's the maximum we could have delivered? I think it's quite timely now, Chair, because we're entering into IMTP planning cycle. So
yeah,
there's a meeting with Welsh Government over the next kind of 4 to 8 weeks. So I think it's important we can describe and understand what's causing the performance to be below target. And are we seeking investment, or even if we've got investment, are there solutions out there? So I think it's just quite timely we do very quickly take down those discussions with health boards, which will happen over the next few weeks.
Thanks, Phil. That'd be really helpful. That wasn't very well. The sound wasn't very good on that. I think we got it though. Thanks, Phil. Then Stephen Harris, then Lauren Fear.
I just wanted to follow up almost where I started the highlight report when we described the role of QSP, the evolving role, and the importance of triangulating or joining up different pieces of information. And obviously, Kath's done a very good job in describing the key challenges and the key solutions. Just to perhaps assure the board, in terms of QSP activity, another important piece of this triangulation would be linking all this back to patient feedback and patient and family comments,
because that is yet another metric in the sense of how content people feel with our services. So that will be something, obviously, we will be keeping an eye on during the course of business at QSP, and not waiting perhaps just for an end of year report to get feedback at the end of the year. So I think we can all recognise the importance of now triangulating patient and family feedback and experience in radiotherapy back to the challenges we're facing in terms of the other measurements as well.
Thank you, Stephen. It's very helpful. Lauren? Lauren, are you?
Sorry, I just want to check on behalf of Andrew. I appreciate Andrew's had slight difficulties in joining, and we tend not to use the sidebar in this meeting. So I just wanted to.
Thanks, Laura. I'm sorry.
I did have a look, Andrew. I couldn't see you in the sidebar either.
Oh, so I'm using the chat. For some reason I'm invisible to you, but I can see you all.
Okay.
And
Okay.
I'm in some Zoom underworld somewhere. I don't know, but anyway, I'm fully engaged with the conversation. It's a really complex, obviously, supply and demand problem, and I mean, patient demand is just going to presumably keep climbing, you know, as an effect of delayed diagnosis when people weren't getting checked out during the pandemic. So this is a problem that's certainly not going to go away, arguably get worse. And I appreciate really all the work on future workforce and all of that. I just wanted, Kath, just to pick up on the Rutherford, because they are only down the road and they do radiotherapy and proton beam and other stuff. Is that a viable option for us? Do they have capacity? I know they're a private organization. Do we have to pay for them? Can they relieve short-term pressure? What's the score there, please?
They can, and yes, again, that's a complex picture. So we have an agreement with them as part of our business continuity arrangements and part of our COVID recovery plan. We have a contract with them to provide a limited number of spots. Swansea Bay also use some of their capacity. So we are already doing that, and we're undertaking an exercise at the moment to make sure that we refer on to them the appropriate patients for them to deliver their care. They are also experiencing some issues in terms of staff capacity, particularly for medical physics, and we're discussing with them, and they were trying to come up with some ideas on how they might be able to increase their capacity. So the limitation at the moment isn't necessarily just the LINAC on time. You know, you could run those machines, I suppose, 24 hours a day if you had one that wasn't fragile and old like ours. But for them, it's the limitation of the staff. Part of the challenge that we're facing at the moment is that they could increase their capacity by recruiting more staff. But given their close proximity to us, you know where they would be recruiting their staff from. So the plan for us to increase capacity with them is to discuss some maybe more imaginative ways of working with them that mean that we're able collaboratively with them to use the capacity that they do have to best support patient treatment in South Wales, recognising that we need to work with Swansea on that as well. So the answer is yes, we are working with them, and we're working with them to see how we can increase that without causing negative impact on the system elsewhere.
Yeah, and presumably we have to pay for it, do we?
We do.
Yeah,
Yes, we
yeah.
do.
Okay, another factor. Okay, thank you.
Because the Rutherford was partly funded by Welsh Government when it was established, Andrew. So, and you know, we've been in discussion with WISC and so on. So, it's all the Welsh Government know that we're using that third sector organisation to supplement or to enhance our capacity. I was going to ask about brachytherapy. I can see that you're writing an expansion business case, and I'm aware of how long those things take. And because what you're saying in the report is patients waiting over 46 days, brachytherapy and urological capacity was the prime reason. So is there anything we can do to hasten getting a brachytherapy business case through to WISC?
We're working as hard as we can on the business case, but we're also working at streamlining how we actually bring patients to brachytherapy and working to maximise our capacity. So we're doing both simultaneously. So I'll happily bring you an update on that at the next meeting for the rest of the board, but I can update you on that in our one-to-one next week, Chair, and we can maybe report back next time.
Thanks. I can Gareth, we haven't moved off radiotherapy yet, but this is, you know, it's an important discussion.
Chair, I think Stephen Allen was ahead of me, in fact.
All right. Stephen Allen, where are you?
I'm here.
Oh, there you are. I'm looking at
sitting
my...
quietly underneath.
I'm so sorry, Stephen, but I can't see your hand up in my sidebar, so I apologise for that.
Right. No problem at all, Chair. That's fine, and thank you, Gareth. Just wanted to come back with more of a generic point, really. And again, we had a long discussion at Quality Safety Committee about the performance report and the information which we sort of being provided. I think the key thing here was obviously that I've listened to the conversation right across the last sort of 20 minutes or so. I think it just shows the complexity of what you're trying to present. But if you're having difficulty understanding what you're saying, how does the public actually read these papers, actually understand what you're doing as well? And I'm really pleased that Stephen Harris, so just to reiterate again what Stephen Harris was saying, it's really important that the patient feedback triangulates what you're picking up. Otherwise, you could be seen as sort of navel gazing into your own performance. So actually check, sort of to do an sense check about people actually use your services. So it's really key. And I'm not going to labour the point because I know I've got a meeting with Kath coming up. It's really important that those things are brought together for people to understand what you're trying to tell them through narrative, through graphs, and to actually say, well, what you're doing and where performance is dipping or where performance is where it needs to be, what are you doing to put it right? Because that's what the public need to have that confidence in that is what you're trying to achieve. I hope that's helpful, Chair.
Yes, thank you, Stephen. I think it resonates to the point that I was making. If we can't demonstrate it through a graph because of some of the difficulties, put it in a narrative, because then that will give the public the confidence and the reassurance that they need. So point well made, Stephen, and I do apologise that I hadn't picked up that your hand was lit up. I've only got one person now, just check on that, which is Gareth Jones. That's the only hand I can see. Okay, no one's countering that. So Gareth, it's over to you.
Thank you, Chair. It feels as if we're in a perfect storm of circumstances here. And I think the question may well be, in any look back on this, were these circumstances foreseeable and avoidable? And I don't know what the answer to that is. But then the linked point, which is on the back of what Stephen Allen was saying, appreciating it's not a quick fix to all of this, but if we do manage to fix it, will that mean that this won't happen again?
Oh, they are two quite detailed questions. I think so. I'm going to do my best.
Try and do a succinct answer.
What I'm going to do is to suggest that I give you a very succinct answer, and that it's something that we can maybe pick up when we discuss in more detail. So foreseeable, you can always look back on in hindsight and question whether or not we should have been looking differently. I think we've been trying to keep a very close eye on what's coming through. I think we are experiencing, we're making our best interpretation of the data, but obviously we are on the receiving end of the service provision that's being provided by the health board, so quite difficult. And so that was the answer. Sorry, what was the second part of the question?
If we manage to fix the circumstances so that we do meet the targets, does that mean that this issue is not going to arise again?
That I think is very difficult to tell as well. I think what we are facing at the moment is we've got the aftermath of COVID. We've got changes in complexity. We also are facing now replacing our LINAC fleet. And initiating the satellite centre. So all of these multiple factors are going to play out for some considerable time and create us additional elements to the complexity of it. So we are going to be experiencing some difficulties for some considerable time. I can see Steve's just put his hand up, so I'm going to come to him. But there was one other thing I did want to say is I think recognising the fact that for some reports we put various different elements of narrative in, then we don't necessarily put them in the next one. I think there's some narrative that we do need to have in there as a standard that we repeat because it sets the context. And I'll make sure that we get smarter at that. Thank you for your comments on that.
Thanks, Kath. Steve Ham?
Thank you. I was just going to add to what Kath said. I mean, the big things that we've discussed which are creating this problem are big problems, aren't they? What we will do is put some short-term things in. what we need to come back to, and probably do it through the IMTP process. Have we got a way out of the big problems over the medium term? And I think that's the challenge for the 3 years. Linux, we know where we are. We're replacing fleet. We know where we are with new hospital replacement, radiotherapy, satellite. Some of these things will help, but as Nick said, they only help if we got a workforce to go with them. So I think bringing those three things together, and anything we can do to make ourselves more attractive as an organization to come to work, I think is really important, which is why I focus when I fed back on where the staff are, because I think just supporting the staff through this period and saying this is where we're going is absolutely fundamental over the winter, and feeding into us finalising our IMTP.
And we will need to look at it, Steve, through the lens also of any patient harm.
Yes.
And COVID, any patient harm.
Absolutely.
So we need to start thinking about that as going forward in terms of how we report things. Kath, I'm very much aware that we've only finished one section of the VCC.
I am mindful of time, Chair. So I was going to suggest that if anybody had anything specific they wished to raise, then I'd be happy to take the questions. Other than that, there is only one other thing I really wanted to note in terms of WBS, if that was possible. But is it appropriate to put that back to board members to see if there's any additional question anybody would like to ask?
Are there any questions on the VCC performance report, colleagues? Stephen Harris.
Well, it's not actually a question, Chair. Again, just to reassure the board, or to assure the board, obviously there was a detailed conversation on the entire document at QSP, which was itself very lengthy. So there has been a detailed discussion of the whole report in a committee.
Thank you, Stephen. So, Kath, if we can go to 7.3C, which is the WBS performance report.
So again, just mindful of time, and as Stephen said, the full discussion that took place in QSP, I would just like to note that the Welsh Blood Service is continuing in difficult circumstances to meet all demand from our hospitals in Wales. And it's meeting that challenge and managing to maintain our stocks, despite the fact that we're seeing more donors not able to attend and not able to attend as life is getting back to some more normal semblance of normal. And we're working on those on communicating with those donors who make an appointment and then subsequently don't attend. But just to note that that our performance remains really, really strong, and that is in the face of some considerable challenge that is being met in other areas of the UK. So just to celebrate that, really. And again, I'm happy to take any other questions that anybody has got on that report.
I can't see any hands up. So noting the context in which you present that report, Kath, and pleased to note that despite the difficulties, through mutual aid, we are still able to help other countries in the UK during this difficult time. And I also note that where there are dips in performance, that's noted, and there is a plan to retrieve the situation. But so Nick.
Yeah, just very quickly, I just wanted to pick up on the foreseeable point from previous discussion, and clearly we foresaw a potential issue within blood services, and therefore recruited a fourth team, which again we discussed at Quality Safety Performance Committee as being the reason why we've been able to maintain performance where other blood services have somewhat struggled. So again, just to demonstrate to board members that we have done as much as we can to staff up and put additional staff in where we could foresee there were going to be issues.
Yep, and I'm presuming that the North Wales team, because some of the difficulties there were with new staff and training and so on, that's I think that gap is closed now, hasn't it?
Yes, it has.
Okay, so looking, I can't see any hands up. Can we go to the trust-wide workforce OD performance report, please? And I presume, Sarah, you're going to talk to this?
Yes, thank you, Chair. I'll just pick up some highlight points, if I may, given that we've had a lengthy conversation here around the impact of workforce supply as is. I'll update the board in terms of the current 12 months rolling absence figure to this Monday is 5.43%. So we can see that actually overall absence is creeping upwards. which reflects the conversation we've just had. Only a very small number of those absences are COVID absences. So we've only actually got 7 staff on COVID absence as of this Monday. However, of course, it's the much broader picture in terms of wellbeing that we're actually talking about in terms of that level of absence. So we're still seeing very much sort of a third of our absence is stress, anxiety related. And we know actually that that is the tip of the iceberg in terms of the wellbeing elements that we know are impacting people's overall sort of presenteeism as well as absence. Excuse me. So, very, very carefully working with people in terms of absence case management approaches there, but also recognizing that we need, and we are working closely with managers to allow them to best impact their teams and the staff within their areas of work so that they can support those people and they can spot any signs of people feeling difficulty or struggling, because that's a very important element of work that we're doing there. So all of this comes together, doesn't it, in terms of the short-term work that we need to do. So for example, daily COVID surgeries happening in VCC to pick up any immediate absence issues, right through to medium to long term in terms of management development and in terms of working through wellbeing initiatives with the wider workforce. So I'll just leave it there, but happy to pick up any questions.
Thank you, Sarah. Are there any observations or queries for Sarah? I'm just pleased, Sarah, to note that given the context you've just described, that our PADR compliance continues to rise. It's small gains, but the trajectory is upwards. And I would be interested to know how we benchmark a little bit against other trusts, because other health organisations, I suspect we're doing very well. So all credit, in comparison, not quite at the target that we wanted, but it is, we're edging ever closer, aren't we?
Yeah, we do compare favourably with other health organisations in terms of PADR.
Thought we would. Okay, so we've discussed thoroughly the performance report and we've reviewed the contents. There's some actions which have emanated from that, which have been captured. So if I can take us now to 6.40, which is the financial report for the period ending the 31st of October. And Matt, I'm going to hand over to you for that.
Thanks, Chair. So this is the report to the 31st of October, month 7. I'm just going to pull out a few key points from the cover paper on the basis that the full report has been taken to the QSP committee, where there's an opportunity to gain detailed assurance, and also on the understanding that members have read the detailed report themselves for their own assurance here. So essentially, if I take you to table 2.1 in the report, this identifies our key performance indicators on finance. So if we start with revenue, we're identifying that we will forecast for a year-end balance position. The key risk around that position was that we hadn't had full confirmation of all of our COVID funding up until this month. We've now had that in writing, so we have strong assurance we can deliver that year-end position. In terms of capital, again, it's showing green, and that means we're planning to deliver our capital program within the funding we've been allocated. Just to flag to members, we have had 2 additional funding opportunities that we've bid for. One was in relation to COVID funding for specific schemes to enable us to implement some important stuff around urgent ventilation work in VCC and donor chairs, etc. We've also had additional funding from the capital monies that Welsh Government have had slippage on an All Wales programme basis. And again, we were successful in getting that funding in, which is being used for digital and other medical equipment investment. In terms of the public sector payment performance, we did have some issues in June, July and August where there were shortages in staff, unfortunately, in the payments team in shared services, and they struggled to cover that. We are now back, though, very close to our 95% target, and I anticipate us achieving the target by the end of the financial year.
Okay.
So in terms of the report, there's nothing else specifically that I'd want to say, but open it up for questions. The only other point I'd like to flag is in the last board meeting, Stephen did ask about whether DOFs was cited on pay inflation issues, sorry, non-pay inflation issues in terms of a risk for next financial year. My responses for this year wasn't an issue and we were covered off in the sense of our financial forecast. I just want to flag that was discussed at the last DOFs meeting and the last Deputy DOFs meeting, where Welsh Government Director of Finance for Health and Social Care was present. We had a presentation from the procurement lead specifically around energy and the All Wales contract. And so I just want to flag to the board that work is ongoing around assessing that risk, because it is a fairly substantial one based on the information that they're presenting around prices. And you'll be familiar with this from your own personal circumstances around energy. But you know, they were presenting potential price inflation of around 100% to 400% on gas and electricity. So we're working through that. Clearly, Welsh Government will need to be involved in those discussions further, and where we go with that in terms of the IMTP and allocations to health boards and trusts. Thanks.
Thanks, Matt. But you don't expect that? Do you expect that issue to affect our year-end position this year?
Not this financial year, no. This is we've brought forward, yeah. So Wales buys forward its energy. That contract is coming to an end, unfortunately, at the end of this financial year. And the prices where they are now, clearly we wouldn't be buying huge elements of the supply, but we're in a difficult situation because, you know, for the actual gas and fuel, our contract ends, and the hike in the prices is going to hit us next year.
So that's next year.
Yeah.
Okay, I can't see any hands up. A very easy report to follow, Matt. Thank you for that. Still no hands up. So we note the contents of the month 7 report, and in particular the prediction that we will meet our statutory duty at year end with a financial break even. So thank you, Matt, for that. And we come then to 6.50, which is the Velindre University NHS Trust Risk Register. So Lauren, I think you're going to take us through this item.
Thank you, Chair. So in the report, there are, in the appendix, are all the risks, meet the appetite that we've set as a board for reporting. And then the cover paper pulls through some focus on the risks rated at 2016 and 15, and also tracks the trend in those risks from previous reporting. So the risk register, as the board will be aware, is also received at Quality, Safety and Performance and Audit Committee. In the most recent Audit Committee discussion on the profile, we discussed the importance of the appetite that we've set around risks with an impact of 5. So as well as the focus on the actual end score of impact and likelihood together, in the next round of reporting, we'll bring through some particular insight and focus on all those risks with an impact of 5 through the organisation. And in QSP, there were some very helpful comments, particularly Stephen, thank you, and Hilary, as to some of the formatting and ongoing improvements that as a team we're continuing to focus on in how this could be presented in a clearer way as possible. In terms of the 20 rated risks, 3 of them relate to the previous conversation in terms of radiotherapy, in terms of targets, resource and equipment. And there is also a Brexit risk there, which the board's information is currently undergoing review, is expected to reduce in the next period. And there's the 5th risk rated 20 is on the outreach project as part of Transforming Cancer Services, which this week received particular focus on that risk in the committee, in the scrutiny subcommittee on the actions being taken around resource, which included this risk. The paper also notes the journey that we're making in terms of the ongoing improvements to quality, and the training and system improvements that we're making. Thank you, Chair.
Thank you, Lauren. I can't see any hands up, but I'm open. Ah, here we go. So I think, Martin, you were first, and then Gareth.
Yeah, thanks, Chair. Just to keep it brief, I think this is helpful. The process has been developed, and it's getting better every time we go through this.
Yeah.
Just in terms of the detail of the risk registers, the risk description about controls to manage risk need to be in sort of two categories, and the column is described as controls in place on the appendix. That means these are the things which have got us to where we are today. However, there's a gap obviously between the risk as it stands today, where we'd like to get the risk to. In other words, we need to do some more work. So traditionally, risk register then have another column is what we're going to do about that, when and who by, and that's what we're missing right now in this format. Whether it exists on DTX further down the line is I don't know, because I haven't done that exploration. But I think in terms of even at this summary level, we need to understand what else needs to happen. When are we going to do it? Who's going to do it? And then the boards can actively measure whether those things are taking the desired effect. If that makes sense to you.
Yeah, it does make sense. Does make sense. Lauren, did you want to respond to that?
Yeah, just completely agree.
Yeah.
Martin, in terms of the formatting, you're right. That's a missing column which needs to be in there. So yeah, we'll work that into formatting going forwards. Absolutely.
It's going to make it ever so hard to read. You can't let the print get any smaller. So there's a challenge for you. Anyway, Gareth, you're next.
Thank you, Chair. I endorse Martin's comments about the point he made. Just a point of detail for me on the cover paper, Lauren, that about 2 or 3 of the risks have historic dates in them for review dates. I haven't tracked across into the appendices themselves to see whether there are current review dates as opposed to historic ones, but just a point of detail to pick up, really.
Yes,
I'm sure you pick that up. So we're on a journey with our risk register. And I'm very grateful to you, Lauren, and the team and everybody that's worked with you, and including Martin, to get us to this place. And we will carry on refining and so on. Are you content, Lauren, that this format is enabling us to pick up and codify the key risks facing the organisation? I'm quite comfortable with it. I'm just wondering what your feeling is.
For me, the main advantage this brings is transparency, because there's no difference between the system that everyone has access to the system. The people inputting the risks throughout the organisation and the managers overseeing them are using this system, and then that's where we're getting the reporting out of it. So it's a challenge in terms of the quality that then brings through that level of transparency. But as we've discussed before, I think it is the right thing to do, and we're starting to see the benefits.
And it's a higher level of engagement, a more ubiquitous level of engagement, I should say, doing it this way.
Yeah, the accountability is clear through.
Yeah. Okay, so we've noted the risks at level 2016, 15 and 12, reported in the Trust Risks Register, and the highlighted risks in the cover paper. We've looked at them in both in the cover paper and in the risk register itself. We've had an opportunity to scrutinise. I can't see any other hands raised. I'd like to note and support the continued work being undertaken on the management of risks in the organisation, which includes the ongoing validation, authentication and mitigation of risks, as Lauren's just described. and that there's a project plan which is in place and actions undertaken to expedite progress in establishing a consolidated risk process for the trust. And we take on board the comments that Martin has made. We'll include that in matters arising and look forward to however they manage to do it to the additional column. But if the print goes much smaller, I'm not sure I'll be able to manage. That's the challenge. Thank you. And so we still on section 6, come to 6.60, which is the Trust Clinical Audit Report. This is an annual report, and this is presented by Nhs. Over to you, Nhs.
Chair. Thank you. So just to give people a context, this report you probably have seen before if you attended Quality and Safety or the Audit Committee. So the report has been endorsed at those two committees. It is here today for approval from the Trust Board. So I'm not going to go through the whole report. You'll be pleased to know. I'm just going to pick up on some key points and just reframe it for you again. So it's reflecting the time period of April 2020. We do remember what it felt like at that point to the end of March 21. And I think we should be very proud of this report, this trust report, which reflects that in spite of the pandemic, there was still a very high input into clinical audit across the trust. This report is bringing together the trust audit activity, probably for the first time in this way. And I do think we should recognize and congratulate the teams for their efforts in doing this. We have appointed 2 clinical leads during the pandemic. Again, another important achievement. So we've got Zoe Gibson leading, a nurse lead for the blood service, and Catherine Pembroke at the Cancer Centre. And their sort of contributions have helped to evolve the clinical audit space. The detail of the number of audits, etc., is in the report in terms of what we were doing. But I mean, I think importantly, we've been talking about radiotherapy, and you may, ask the question of what was happening to radiotherapy during the pandemic. And the answer to that may in some part be reflected through the UK COVID radiotherapy project. That meant that every single patient that we treated during this time period was entered into a UK database for radiotherapy. And those results, we will, there has been an initial report in the Lancet. There will be a further report next year to almost give us the sort of overall, what did the impact do? What was the impact of the pandemic on radiotherapy outcomes? So I think we will be looking to see that result early in the new year. I think that moving forward, we have got ambitions for us to integrate the audit positioning and relationship within the sort of framework for quality and safety that Nick is working hard on. We've also got the National Clinical Framework, which gives us some levers for the positioning of clinical audit. So how can we take things to the next level? We look forward to bringing back sort of a reflection of that through the next iteration of the clinical audit plan for the trust. So the report in summary is providing assurance to you all that clinical audit remains a high priority for the trust, that it is being conducted according to the principles that we have set out for ourselves, and that high quality care continues to be developed, to be delivered, and also that this is now being embedded more consistently through the organization. I mean, it's not perfect as yet, but I think what we've done in this report is actually to demonstrate that we've been doing pieces of work that we haven't necessarily classed as audit. So it's been a kind of attempt to bring things together, and also the emerging importance of continuous quality improvement. How do we now layer that on top of these pieces of work? So I hope that you are reassured, and I hope that you will be will agree to approve this report today. Thank you.
Thank you, Jazz. Are there any comments or observations for Jazz? While people are thinking, Jazz, I noticed that on page 5 in particular, in relation to the section which precedes it, which is mainly about radiotherapy, but not entirely, but there are a number of challenges there. Key points that need addressing is the subheading. And I'm just wondering if you want to talk us through any of those and to just alert the board as to how you might overcome some of these challenges.
Yes, thank you, Chair. So, I think this was the report from the Cancer Centre, and very much I think this is Kath Pembroke's personal views on what we need to do, which we asked her to kind of put in. So I thought that would be helpful. So I think that we have done some work around quality improvement through the grand rounds, you know, initially tackling largely the medical staff. And actually we did a survey as well of people's understanding of quality improvement. We had an international speaker from the States talking about quality improvement in the context of radiotherapy. And what it did demonstrate was that, you know, if you're a new trainee now, you get all of this in your training, quality improvement, you're sort of, you know, you have to participate in it. Whereas, you know, there are some of us, and I'll include myself in it, where we probably haven't had that as part of our training. And we may have missed the opportunity to participate in quality improvement at all. So there is a need for us to understand what is that requirement for us to be able to engage in quality improvement wherever we are in the clinical journey. And so there is work going on to try and identify who needs the training, how we can deliver that in-house. And the senior house officer engagement, so these are the kind of trainees that come, they're only here for a short time. It's quite difficult, therefore, get them involved in things. So what we're doing now is actually getting things ready. So you almost in your induction, you'll be presented with a possible audit that you can participate in so that it's more systematic. We do want to increase spatial engagement in our project. So it's a bit, you know, it actually touches on some of the conversations we've had today. We can do a piece of work, but how do we get the feedback from our patients about their participation in it? What does it mean? So there's an active question now when you fill out an audit proposal in terms of, is it a relevant question to get, is it a relevant area or topic to get patient engagement, yes or no? How would we go about doing that? The relevance of national audit data to our local population. So we're very good at participating in national audits, but actually we don't get Wales results. This is one of our problems. We get the UK results, but rarely is this broken down to give us, you know, the specific all Wales results. So this is something that the CMO is aware of and that we have raised nationally. And it is to do with data sets and you know, data information governance, but it is being looked at a national level. I'm not quite sure when that will be available, but it has been flagged. And also the use of AI in helping us to understand actually collate data, use our data, and also collect patient-reported outcomes. There is a KES PhD student, in fact, from Swansea, who is doing a piece of work on this. He's got an AI background, and I can share more details with you to come. So haven't got all the answers, but we are starting to work on these areas, Chair, if that's helpful.
Oh, thanks, Jazz. And I think perhaps in relation to the last point you just made, some kind of business intelligence for data that comes from all kinds of sources is something, looking at Steve who's looking down, that we need to think about, because at the moment it's left to individuals sometimes to work out what various data means to them in their service, and it would be really helpful if there was a mechanism by which we could have that analysis performed for us. Challenge there. Martin?
That's very timely, Chair, because one of the things I was going to mention on business intelligence is that Audit Wales now have a business intelligence team as part of in their sort of Cardiff office, and they've actually been looking for projects, particularly in the health service, where they'd like to get their teeth into in terms of turning raw data into real helpful information for us in terms of being able to sort of improve our systems. And so we absolutely should be engaging them and seeing if they could help us. They have all the various bits of software, etc., to stick things into, and they obviously can do all those comparators across Wales and indeed, I guess, with the NAO across the country if necessary. My general comment was going to be one just about, and this is another piece of that triangulation of the governance and good assurance puzzle. And Gaz is going to come along to Audit Committee recently to talk through some of this stuff. And I think it's really, really helpful that Audit Committee's had a bit more prominence in terms of understanding where clinical audit is going. And we absolutely receive this annual report, and I think we probably need to receive briefings more regularly to understand exactly how it works. But again, it just fits into this overall assurance framework. It's come up several times today, and will continue to do so. It's really helpful to understand how these bits of assurance we get and how we fit them together. Thank you, Chair.
That's an important point. Well made, Martin. Thank you. I can't see any other hands up. So we're asked to approve this report and to continue to support the function of clinical audit. I doubt anybody's going to say, no, we're not supporting, continue to support the function of clinical audit. Of course, we support that. And I move with that we approve, as a board, we approve this report. Thank you. We're now supposed to have a break, but I would like to get us to a point of finishing, if I can, within the next 20 minutes or so. So with your permission, everybody, I'd just like to carry on for a moment and take us to section 7, strategic development. And the first one, 7.10, is the Equality Ambassador Showcase. This topic, this board meeting is on religion and belief. And I'm going to ask Sarah Morley to talk to this item, please.
Thank you, Chair. Thank you, Carol. So first of all, just to give some context to colleagues that may be joining us for the first time, each member of the executive team is an ambassador for one element of work that we do under the Equality, Diversity and Inclusion umbrella. And this is the third Ambassador Showcase presentation that we've had at board. So I'm very happy to be presenting today. The area of work that I'm ambassador for is religion and belief. So what I'll be taking you through are some of my early thoughts really in this work. And as colleagues will know, as an executive team, we're exploring our ambassador roles at the moment and just sort of thinking through what they might mean for us and what they might mean for the organisation. So if we can go to the next slide, please. So the first thing really in terms of thinking is, how do we support staff to actually participate and share their elements of religion within the organisation? And we are active participants in a range of activities through the year, and our religion equality profile is very active. We do this in a number of ways, particularly through Interfaith Week, which is happening in November. What you can see here are a range of images really, which represent festivals and celebrations which take part across the range of religions which we may well have be part of within the organisation. We regularly communicate and attempt to share stories and information and really raise awareness of elements of the different faiths that people may have within the organisation. This is really to support the idea of bringing your whole self to work, which we know is fundamental to people engaging in the workplace and actually reaching their potential. And that's absolutely what we're supporting through this work. If we can go to the next slide, please. What I tried to do at the start of my ambassador role in this area of work was think about, okay, what are the key aspects of religion and belief that I need to think about first. And I started to think about the cancer centre, particularly in terms of our patient services. So just having a conversation there with our chaplain, Christine Powell, and just to understand really the services that we provide for patients, just to understand the impact that can have on people who need to access our services, which we know can be at a time of very, very great deal of personal difficulty. So we actually have a wide ranging offering really for patients. We draw on a team of chaplains. We have a service level agreement with Cardiff and Vale University Health Board, and Reverend Christine Powell is the key person there that is our constant. However, really recognising that a Christian chaplain is not what we should be doing in terms of its entirety. So we draw on a team of chaplains that represent a wide range of denominations and faiths, and those are people that we can call on at really any time of the day and night if we need to support the spiritual needs of patients and their families. They work very closely with the palliative care team and really recognise that having the close interaction and understanding of how the system works and how therefore they can best support patients and their family is key to making the difference in terms of that spiritual need. Also recognising that the way that we actually develop that service with patients is key. So what I mean by that is, Christine was describing to me, and it's something that really resonated, that people may return to their religion at that point in their lives. They may be end of life, or they may just recognise that they're going through something that they've never been through before. And they may therefore turn back to childhood experiences in terms of their religion, even if they haven't been actively practicing that religion through their adult lives, if you like. And really describing how the conversations can really support people, where they might decide to have conversations with our faith leaders that they cannot have with families or loved ones because they're in a particular area of difficulty. Also recognising that we can and should support colleagues. This has happened particularly during COVID, and colleagues will know that we had a wellbeing area in the Maggie Centre where staff could actually take time out. And particularly we lost a member of staff, of course, quite early on in COVID. And the Reverend there was particularly instrumental in supporting staff through what was a very, very difficult time in terms of their own well-being and just coming to terms with what had happened as part of that workforce. Also recognising, of course, that all of our clinical staff in the Cancer Centre need to understand the importance of spiritual care and signposting for patients where necessary. And that education is key because this is part of our holistic package of care for patients. And of course, in terms of a physical presence, we do have a multi-faith room in the Cancer Centre. And whilst it seems to have a particular presence in terms of maybe Christian faith, actually it's widely used by people who practice different faiths where they need to go to undertake daily prayers and so on. And there's a range of actual resources in that room that are used by colleagues. Probably less so now during COVID, but actually very much so before that. And we have had weddings take place in that room and so on. So if we can go to the next slide, please. So in terms of what this means for me as a trust ambassador, first of all, just thinking very carefully about the whole area of work. This is religion and belief and non-belief. And that's a very important thing to consider, that people may not believe or have a faith, and we need to protect their right in that respect as well. But also recognise that belief is not just religious belief. And that actually it's a range of beliefs which sometimes might contradict with work we do in other areas in terms of protected characteristics. And there's a lot of conversation happening nationally in that area at the moment, and we need to think our way through that and tread our way through that quite carefully as an organisation. We also need to recognise intersectionality. So how does religion and belief actually intersect with other areas of particular identity that people have and bring into the workplace and support people in that way. Of course, we need to support our patients, our donors and our colleagues, and I've concentrated on patients today, but really we've got lots of work to do across this much broader area. And of course, we need to practice allyship. So how are we an ally for people in terms of supporting their rights in this area, but more than that, being visible in terms of role modelling. If we can just move on then to the next slide. Thank you. So in terms of action that we need to take, as I said, we are very active in this space, but clearly there's a lot more that we can do. I'm very much looking forward to working with our new equality manager when they take up post with us at the end of January. We need to show visible leadership and be accountable in terms of zero tolerance of discrimination, wherever that might take place. And also give staff a voice. So how do we ask people what they need in this area of work? How do we actually engage with people and have an open dialogue and really demonstrate that we are listening? And as I said, practice that active allyship. As we do with all of these ambassador presentations, we do run the presentation first with Exec Management Board, and we did that this week on Monday. If we can go to the next slide, thank you, Carol. So in terms of our EMB discussion on Monday, we had a wide-ranging conversation actually, and this is just demonstrating now how valuable these ambassador presentations are and these conversations are. And some of the reflections really from that meeting is that, you know, it seems awkward to talk about religion, and especially in our culture, we find that quite a difficult conversation to get into. So how do we actually break down some of those barriers so we can have that open discussion really? We certainly need to gather greater knowledge, so we each gain in confidence. And in individual conversations I've had with board colleagues where people say, I don't feel confident to step into conversations around ED&I aspects more generally, but also in terms of religion and belief. We certainly need to ask staff, as I said earlier on, and we need to talk to patients and families to understand what else we can do, because we mustn't assume that we're meeting the need. We need to better understand that. And really also recognise that this is one of the most important conversations that people might have at the end of life, and our role in that to actually make sure that we facilitate that in the best way that we can. That's the end of my presentation, Chair, so we can take the slides down now. Thank you, Carol.
Thank you, Sarah, and thank you for your presentation. The take that I've always had is quite simple, really. What is spiritually important to patients and families in health, and how can we as a workforce assist patients with what's important to them in a time of illness? Because, you know, we are dealing with illness. Blood donors, I need to think that through a bit more carefully. But the other thing I was going to say is I've been part of a European-wide initiative to develop spiritual competencies across professions, and, you know, including all faith groups. And one of the people who was most influential in that is working just up the road, Professor Linda Ross. And I just wondered if, and she's led that project from a UK level. Malta was the lead country, and for the UK, Linda, who was in the University of South Wales. And she just might, they have developed a spiritual competencies framework, which cuts across, if that's the right word, all faiths and none, and might be useful just to have a look at.
Yeah, thank you, John.
I'll contact Linda if you like.
Yes, thank you. I much appreciate that.
I can't see any hands up. It's I don't know if that's because you've said everything that needs to be said, but it was a very sensitive presentation, Sarah, and I'm thank you for that. We're just asked to note this presentation and to look forward to the. Oh, Martin, you've got your hand up. Sorry, Martin.
Yeah, conscious of time, so certainly don't want to drag this out. But I think that this is really, really helpful, Sarah. I think recognizing, you know, when we talked a couple of weeks ago, we talked about how each of these characteristics, these areas, these ambassador roles overlap. So, I mean, the intersectionality thing is really important, isn't it? Because we know that people who have strong beliefs, sometimes those clash with other beliefs that other sections of society have, and other, in fact, laws of the land are. So I think it's being very sensitive about how we respond to people who say certain things, who behave in certain ways, be that staff and patients and donors, I guess. So recognizing that the tolerance and respect that is necessary in these areas is very difficult, isn't it? You know, for example, there was an Australian rugby player not so long ago who openly said that he didn't believe in homosexuality and gay marriage and a whole bunch of things. And you know, just counselling people about when it's appropriate to say certain things in certain situations is going to be very careful, because clearly, you know, that was a deeply held religious belief, but it doesn't sort of mean that necessarily be out there for the world to hear in an official capacity. So how we manage people who say things which others may disagree with is very sort of nuanced, isn't it?
Yep. Well, of course it is. Of course it is. But we're also a country of laws, so we have to be mindful of that as well. And there has to be something which is about equity. I'm not going to say equality, but it's something about equity. So for certain faiths, there are certain times of the year which are the most important times of the year for that particular faith group, and to make sure that we're doing everything that we can to help individuals in our care to observe those special times, you know, Easter, Eid, and so on. We had the chaplaincy service. We got a review a little while back, and I can't remember what report that came to us in. I think it might have come through the charity, because it's the charity that funds the chaplaincy service. So I need to look at that again and see what that was saying, Sarah. You've probably done that already, to see if there's anything we need to pick up from that.
Yeah, that's another thing we need to go back to, Donna.
Yeah, but I take your point that just having one chaplain of a particular denomination, but I know that she'll work across all faiths to assist individuals. So she isn't just, I mean, I remember when I used to work in Llandoch, we'd have a Roman Catholic priest who would come in, and he'd ask who are the Catholics, and he would go and see the Catholics. And I know that our chaplain does not do that. Everybody's included in her embrace to help people through their difficult journeys. I can see, Steve, your hand is up.
Sorry, I need to take myself off mute. I should have before. Just quick points really. In terms of, we've had 3 of them.
Steve, you're breaking up a bit.
I shout through the wall, Donna.
Okay.
No, in terms of there's some themes coming out of this, I think that we probably need to take away. I've been thinking about this since Monday, Sarah, so if you look at the phrase pieces of work that you, Jazz and Carl, I think we can already start to draw some things out that in the intersectionality frame that we actually can start to think about how we change the organisation. I just think because by the time we get through all of these, we'd be probably the end of next calendar year, and we probably need to start teasing some things out, both specific and more general. So I think you and I can have a conversation about what we do with that. I think an update the board.
That would really be helpful. Sarah?
Yeah, sorry, that was quite hard to hear, Steve, but I think I understand your point in terms of the themes. And clearly this has got to underpin our programme of work as an organisation now as we move into 2022. And as I said, with our new quality manager coming into post, you know, we've got an ideal time to regroup our plan and our programme. And I've also had very useful and important conversations with members of the board in terms of our board development programme for next year around ED&I, which have also elicited many aspects of work actually we want to prioritise and see as part of that plan for next year. So lots of things triangulating again in terms of our drive forward.
Thank you. I can't see any other hands up. So we note the work to date, and and we look forward to seeing this develop as with all aspects of our ambassadors working with ED&I. So I am mindful of time. We come to 7.20, which is the Strategic Development Committee highlight report. So if I can hand over to you, Stephen.
Thank you, Chair. Again, in the interest of time, I'll be as brief as I can. Obviously, we need to give it due consideration. But you'll be pleased to see this is a much shorter report than the QSP report, because we consider fewer topics, but in much more strategic depth. So I'll take it as read, just perhaps two things to highlight. One from Advise, which is something Matthew touched on earlier, in terms of capital funding that's been made available to the Trust by Welsh Government to support COVID recovery. So that, again, we had a report on that in the committee meeting and a discussion around that. And then the only other thing to pick out is in Assure, the work of the Collaborative Cancer Leadership Group, which is a clinical-led group. We had a presentation and an update on that, very much around exploring our role within the regional system, our role along patient pathways, and how we can further contribute and develop to, in a sense, regional and national pathways in an even more joined up manner. So that was a very interesting presentation. There is a workshop being set up to take that to the next step or next stage, and that workshop is going to be held in January 2022, and clearly we'll get an update report coming to the strategy committee following that in due course. So I say I wasn't going to dwell on anything else, Chair, but I'm happy to take any questions.
I can't see any hands up, Stephen, so thank you for that highlight report, and we'll note that report. Thank you very much. And move to 7.30, which is you again, Stephen, Transforming Cancer Services Programme Scrutiny Subcommittee highlight report for the meetings held on the 21st of September and the 25th of October.
Again, thank you, Chair. So two highlight reports here for two meetings held, as you said, in September and October. These reports also go up to the QSP, but come to the board as well. Again, I presume people have read both of the reports, so I'll just pick a couple of things out. In terms of the meeting on the 21st of September, we received the finance report, which was demonstrating at that time a small projected overspend at the year end of around £30,000, and a discussion of how that might be managed by the year end. And we also then received under assurance and a progress report on the Nuffield recommendations. So I'll move on to the second one, if I may, Chair, which is the October one.
Thank you.
Again, we received actually, just to correct, it's a TCS finance report at the top of Advise there, with the overspend at that point had come down to a projected year-end overspend of around £17,000. We were noting that there's, at that point, projected overspend on capital by the year end in relation to the integrated radiotherapy solution procurement. So clearly that's something that's going to have to be managed and handled by the end of the year. Other than that, Chair, as I say, I'm happy just to take any questions people might have on these two highlight reports.
Thanks, Stephen. Again, I can't see any hands up. So I'm taking it that there aren't any queries for Stephen, and we note both of those reports. And now we come to section 8, which and the first item there, 8.10, is the Audit Committee highlight report. So Martin, I'm handing over to you for this.
Did we not just miss 7.4?
Have I? Oh, comms. Yes, I have. Sorry. Thank you all.
So again, we'll be brief. So as Steve mentioned in his CEO update, there's been a focus during this period around supporting the engagement of comms for our preparation, and then during some initial clearance works to support ground investigations on the site of the new Velindre Cancer Centre. And some of the engagement with the community and media is detailed in that first section. And 3 focuses I'll pull out for the next period around continued engagement on our competitive dialogue for the new Velindre Cancer Centre, the way in which we're working with our health board partners on developing ongoing messages about how we're developing services as a region. And then thirdly, so this is particularly outward facing now, update on frequently asked questions and some mythbusters, which will go through our various channels.
Thank you, Lauren. I can't see any queries for you, Lauren, so it's quite self-explanatory. Short paper, which kind of hides really the huge amount of work that's involved in what's contained in that one paper. So we note that report and come to section 8, integrated governance. First, as I said, Martin, try again to hand over to you to talk to the audit committee highlight report.
Unless Stephen wants to do it, of course, he's chairing all the other committees at present. This highlight report is about the audit committee meeting we had on the 14th of October, and it's reasonably self-explanatory, and indeed some of the topics here have been brought up already. For example, we've already discussed clinical audit annual report, and we've already discussed the trust risk register. In external audit, I won't rehash the issues we had with the stock take for at year end last year, but more widely we received the audit report from Audit Wales, which was a very positive report. There were 2 recommendations, but they were minor in nature and have been accepted and going to be dealt with, resolved. So nothing significant to report there. Internal audits, we received quite a number of audit reports, 1, 2, 3, 4, 5. They're all a reasonable assurance rating for those people who aren't au fait with the labels of all audit reports. They issue 4 categories. There is a substantial, which means everything is just about perfect; reasonable, which is above the bar and very good; limited, which means below the bar and things need to be fixed pretty quickly to get things right; and pretty much a no assurance report, which means things are entirely pear-shaped. All of these, as I said, are above the bar in terms of reasonable assurance ratings, and no major critical issues were flagged in any of those reports. And the last topic we discussed at audit was about counter fraud progress reports, and you can see the number of days have been undertaken, and 1 active investigation is currently underway. Just to quickly connect to the very bottom line, the inform line. There's been an issue with Craig Greenstock, one of our counter fraud managers, was severely affected by COVID and was hospitalized for quite some time, has not come back to work, and indeed is taking early retirement. An advocate has gone out to recruit an investigator, and indeed conversations are happening between Matt and Andy Butler over at Shared Services Partnership about what's the appropriate level of counter fraud activity we need to have within the Velindre family, and whether the number of days we currently spend is sufficient to tackle what undoubtedly there is fraud out there, and make sure we address it appropriately. That's all I have to say.
Thank you, Martin. Any queries for Martin? Thank you. So we note that report, and the next one is the other committee that Stephen Harris doesn't chair, which is the Charitable Funds Committee. So that's down to me. We started our last meeting with a view from a fundraiser. This is a process that we've started. Every other meeting we bring one of our fundraisers in to talk to us about their experience of fundraising, and we connect with each other really, and we're able to talk to them about how we use the funds to support our patients and our services. So we had Tracy Davis last time, who was recently awarded the British Empire Medal, and very inspiring that session was. Fundraising, the figures show that following COVID, in which there was some dip in fundraising activity, things have now started to improve, and November in particular has been a very busy month for the fundraising team. A couple of events happening every week. And since the appointment of our interim charity director, there's been a comprehensive training and development programme, which has been very much welcomed by the staff in the fundraising department. We are going to produce an annual report. It's nothing which is required of us, but we just felt it was appropriate to have an annual report and to present it to our fundraisers at a gathering. Again, this is all about connecting with those who work so very hard to raise substantial amounts of funds for us every year. So we're going to have that meeting in January sometime. I think there is there's a date, and you will all be invited to attend that meeting. But what we do have to do is our annual accounts. That is a requirement for the Charity Commission. And we are going to have an extraordinary meeting on December the 21st or the 22nd, thanks to Emma Stevens, who I'm not going to say it, but fancy putting an accounts meeting on 2 or 3 days before Christmas. Emma, I'll never let you forget it. But looking forward to receiving our annual report, which we're required to present to the Charity Commission. I think it's December the 21st or the 22nd. And I think those really are the main issues. We did approve a business case for the Advanced International Fellowship Programme Medical Training Initiative. This is for fellows, and it's been very successful so far. We've approved another 2 years of funding, and we will look though for an exit strategy at the end of this 2-year cycle. And we received a number of business case expenditure evaluation reports. So for colleagues who are not aware, when you're awarded funding for whatever the project is, and we expect an annual report on progress and the end of initiative report, and we've been really tightening up on making sure that we get information to assure ourselves that these projects have been undertaken appropriately and in accordance for the reasons that the funds were approved, and so that's getting a bit better. The content of those reports is getting a bit better. So that's all I would want to say, and I'll take any questions. I can't see any. Thank you very much, colleagues. So we note that report. Now we come to 8.3, which is the Blaenavon Data Centre Transition Project. I note that Stuart Morris has joined us now. So Stuart, I will hand over to you, but before I do that, I want to say, Stuart, this is going to be your last Trust Board meeting that you'll attend in your capacity as Chief Digital Officer, because moving away to do missionary work in other parts of the NHS in Wales. How could you do this to us? No, but all joking aside, Stuart, thank you for everything that you've done in this organisation. Absolutely immeasurable. I think the contribution that you've made to this organisation, and to wish you every success in your new venture. You won't be as happy as you are here, I'm telling you now. But seriously, Stuart, all the very best going forward. And I'll just hand over to you now to present this paper.
Thank you, Chair, and I really appreciate those comments, even the ones that I won't be that happy going forward. But no, I really do appreciate it. It's, well, I wasn't actually expecting to be here, so I really haven't prepared anything, which is unlike me. But I just want to thank all colleagues for their support throughout my sort of 22-year career within the trust, but actually the last 5 years working so much more closely with the board and the executive team. So yeah, it is going to be strange. It's definitely going to be a big step for me, and a change in lifestyle I expect as well, but looking forward to the opportunity. So, and I'm not going to be too much of a stranger. Clearly there are things that really link across the region. So, I won't be a stranger to Velindre. So thank you all. I appreciate that. In terms of the paper, as colleagues will be aware, that I've kept the board and executive team updated regularly on the progress of this Blaenavon data centre transition over the past 6 months or so. And while the paper's there, and I don't intend to go through it page by page, but I think there are two salient points to really pull out. And firstly, one of them is just in way in which this has been managed from Digital Health and Care Wales perspective. It's been an excellent piece of work, very professionally managed. They've kept 2 times and kept to the tranches as planned. Clearly, there have been things that have needed to iterate as it's gone along, but all of those have been controlled. So I think it's really important that we note that the excellent work they've done. And secondly, actually, related to that is clearly the concern that we had specifically for the Cancer Centre around the CANISC system. And again, it was the long weekend at the end of August, the August bank holiday, but that was a seamless transition. As a service, we didn't experience any kind of difficulty at all. And we now have a resilient service, again, running out of the 2 national data centres. That doesn't say that the CANISC risk goes away. And clearly a priority for 2022 is for, and a focus for the Cancer Centre is really that transition away from CANISC. But it's good to know that we are still have a very resilient service as we are today. I'll pause there and take any questions.
Any questions for Stuart? Yeah, we were all holding our breath, weren't we? And it's gone much smoother than any one of us anticipated and to time just about, Stuart. So that's very welcome. And we need to express our gratitude and thanks to our colleagues at Digital Healthcare Wales. They did keep us very well briefed and updated every step of the way through newsletters and so on. So well managed. I'm not sure who's first, Martin or Steve.
I'll go first then.
Okay, you go first then, Martin.
Yeah, Stuart, thank you. Really helpful paper. And I think it's, given the context of how this kind of came around in a rather hurried, panicked position where comms at the beginning of this wasn't great, and we were kind of rather being foisted upon, and the panic that caused around the audit committee and elsewhere. I think this has been a terrific result. So congratulations, Stuart, to you and team in terms of making sure we're working with DCHW and getting this done. I understand the journey is not complete, but a very substantive step forward we've made. So thanks.
Thank you.
Thanks, Martin. Steve?
Just to agree with Martin, really. It's easy because something's gone really pretty smoothly, actually, to forget how big a job this was. This is not a mean feat, moving all this I could call it stuff in a non-technical way, Stu, but we used to be using that sort of language. From where it was to where it is now and getting it across is just huge, and it just happens below the surface. And I think that's what tends to happen with the IT infrastructure stuff. We only really become aware if it doesn't work very well. And I think the scale of this project and to get it over the line in the way they have has been excellent. Yeah. And they have communicated really, really well about what's going on.
Yeah, absolutely.
Yeah, thank you. Thanks, Steve. Stephen?
Just firstly to, again, a big thank you to Stuart for all he's done for the Trust over the past 22 years. And certainly over the past 4 or 5 years, I've known you, Stuart, working together. And I just wanted to add to the Steve Ham's comment around the scale of the challenge, because clearly, as well as all the technical issues, which had to be sorted out, in some ways, even more importantly, there were all the information governance issues that whatever we did at all times had to protect the confidentiality of patient, donor and staff information. So all that work's been going on in the background, and that's not the sort of work that can be reported in detail in public because of the very nature of cyber threats and cyber attacks. But I also wanted to say a big thank you to Stuart and the team for the huge amount of work that's gone on in the background, not just technically, but from a very important information governance point of view, that you've protected all of that very, very private and confidential data. So thank you.
Thanks, Stephen. I'll make sure that's passed back to the teams as well. Thank you.
Okay, so I can't see any other hands up. So we welcome this report and note its contents. And Stuart, I hope you realise I was just teasing you. Of course,
yeah, of course I do.
I'm sure you're going to be very happy, but I stick by my words. The contribution that you've made to this organisation has been immeasurable. and I personally have benefited from the wraparound support that you give us. Oh yeah, you're all back. So Stuart, there'll be another chance where we can say cheerio on you know, on an informal basis, but on behalf of the board, can we have it minuted, please? Our enormous thanks to Stuart for his enormous contribution, and to wish you well in Cwmtaf. The door is always open for you.
I'm not going to delete your number. You're all right.
Great. Okay. I haven't been informed that there's any other business, so I think at this point in the afternoon we probably wouldn't take it unless it was absolutely crucial. Does anybody want to raise any issues? We've kind of raced a little bit through the, not quite raced, but we've gone at quite a quick pace through the last couple of items. Does anybody want to raise any issues that they felt that they didn't have a chance to raise as we were going through the items, and it's occurred to them since, so they'd like to raise it now? No. Okay then, so the date and time of the next meeting is the 27th of January at 10 o'clock. I'd like to wish everybody that I won't see between now and the 27th of January a very happy Christmas, and I hope everybody has the opportunity to take some time off to be with family and friends and to have some downtime. I can see Lauren's got her hand up.
Sorry, I didn't not to interrupt. I was just going to make the talk about timing for the afternoon. So you do your important bit. In terms of the well wishes, and then...
Yes. So I think we need to come back at 2. I hope that'll be long enough for everybody, but we probably need to come back at 2 for reasons I'll understand, the colleagues will understand when we come to part B. But I'd like the board now to adopt the resolution that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest in accordance with section 1(2) Public Bodies Admissions to Meetings Act 1960, paragraph 67. Thank you everyone for your contribution today. Sorry we've run over a little bit over time, and I'll see you all, those who are attending part B, I'll see you at 2 o'clock. Thank you.